Hi everyone. Welcome to our LIVErNORTH March meeting. Our speaker tonight is Rodrigo Figueiredo, and Rod did his training at Newcastle. But what he doesn't know is that we knew he trained at Nine Wells. That's where you got you first did your medical training.
That's right.
Great hospital, actually. We knew it well, and on the banks of the Tay.
Yes,
And lovely. So just on the Perth side of Dundee.
that's right.
Yeah, very good. So you haven't been very busy since you came to Newcastle. You've only done 53 published papers. And I know that you're really getting stuck into the transplants. And of course, you are now a transplant surgeon at the UK's only Institute of Transplantation. And that's an honour in itself.
It is indeed.
So Rod's going to talk about perfusion, and we've had some talks on perfusion in the past, but it changes all the time. And I'm not going to steal his thunder. You'll find out what it's all about when I hand you over to him. Now, have you got some slides, Rod, to share?
I do, yes. Can you enable sharing for me,
Yeah,
please? Yes.
I've done that now. So it's all yours.
Fantastic.
You should be able to share now. That's good. I can see that. Can everybody see that?
Yes.
Excellent.
Oh, that's working. You can see my slides okay?
Yep.
Great. So thank you very much for the opportunity to speak to you all. It's an honor and a privilege. My name's Rod Figueiredo. I'm one of the consultants in HPB and transplant surgery at the Freeman Hospital and at, as you rightly say, the Institute of Transplantation. I've been a consultant since 2021, but also did most of my training here in Newcastle, so have been here for quite some time. I did a PhD in organ perfusion, specifically into liver perfusion, which was partly funded by LIVErNORTH. So I'm very grateful for the support that I've received from LIVErNORTH over the years. And I'd like to share with you some of what is currently happening in organ perfusion. And as you rightly say, that it's a constantly moving field. And over the last 10 years, the advances in organ perfusion have been pretty dramatic, but also the impact for our patients, I think, has been very dramatic as well. So I'll start by giving you the background to this, why this is important. And this is the latest published data from NHSBT on the liver transplant waiting list. And apart from the dip at the peak of COVID, where a lot of patients got suspended, there's a steady continuing trend upwards. And that is unfortunately not matched by an equal increase in the number of donors. And so therefore, we have a supply and demand mismatch. More and more patients are needing liver transplants, but the organ donors, if anything, good quality organ donors have been in decline. You can see this is the data for the last 10 years or so of organ donors. Now, some of my slides will get a bit technical, so please don't hesitate to interrupt me if there's something that I say that doesn't make sense to you, or you want me to explain it in a bit more detail. I've got all the time in the world, so please don't let me say anything that doesn't make any sense to you. But I assume a lot of you will be familiar with the terms of DBD and DCD, and that is donation after brainstem death and donation after circulatory death. Traditionally, most livers around the world, and particularly in the UK, have been done from donation after brainstem death. Those are donors that have a beating heart up until the moment of organ donation, but are brain dead. Those are the dark blue bars there, and you can see over the last 10 years, actually, if anything, they've been going down. And although the latest 23-24 data is not yet published, I'm pretty sure that's going to have gone down further. DCD livers have been traditionally associated with significantly worse outcomes for recipients. So if you get a liver transplant from a non-heart beating donor, the chance of having complications specifically relating to the bile ducts has been significantly higher. And so there has traditionally been a reluctance to increase the donor pool by utilizing livers from DCD, that's non-heart beating donors, because of the added risks. However, over the last few years, there's been a definite trend upwards nationally. But the important thing is that as we try and utilize more marginal donors, that we do that safely. And that is always the primary objective, is that if we are trying to push the boundaries of what is acceptable, the safety of our patients has to be paramount. And so we have created a system in Newcastle, which is part of a national liver utilization system, but specifically here in Newcastle, we investigate any livers that we decline that are then subsequently used by any other centers. And the reason we want to investigate that is that these are potentially missed opportunities for our recipients. If we have patients on our waiting list and we say no to a liver that then somebody else uses and has a good outcome, then that's something that we need to learn from and reassess as to whether we are making the right decisions and whether we should be pushing the boundaries a little bit more, perhaps. So for every liver that we decline that someone else uses successfully, we discuss that as a team so that we can have learning points from it and so decide whether or not we made the right decision or not. Ultimately, the decision as to whether to accept particularly a marginal liver, so that's a liver from a donor that is considered a higher risk, that is a very difficult decision to make, and lots of factors are taken into consideration, both with regards to the donor and the recipient, to make sure that that's an appropriate risk. And we take our patients along with us on that ride to make sure that they're fully aware of what we are doing. That's just explaining our liver declines audit that we do. And as we have gradually over the last few years increased our appetite for risk, we have continued to very closely monitor our outcomes to make sure that we are not taking too much risk, that the risks that we take are very carefully calculated to make sure that we continue to do it in as safe a way as possible. However, in doing so, I showed you before the data, the national data on DBD and DCD utilization. And you saw that there was a bit of a trend nationally to using DCD, that's the non-heart beating donors, more and more over time. But that is seen even more so than anywhere else here in Newcastle. So in the last year, over half of the liver transplants done in Newcastle were from DCD donors, which is more than any other centre in the UK. Not only are they DCD, they are DCD donors with other significant risk factors as well. Lots of them are older donors who have the liver blood test may have been abnormal to start with. And the problem with that is that traditionally, taking that sort of risk has been associated with a significant rate of what we call ischemic cholangiopathy. And that is when the bile ducts don't survive the process of donation very well and then develop what we call ischemic cholangiopathy, which is where the bile ducts shrivel up and stop working properly. And whilst the liver, some of the liver functions may continue to work, it stops producing bile and those patients become jaundiced and eventually need another liver transplant. Now, historically, before the advent of widespread machine perfusion, that happened in about a quarter to some series up to a third of liver transplants done from DCD donors. But by using machine perfusion, which we now routinely do for every single DCD liver transplant in Newcastle with no exceptions, so any DCD liver before it gets transplanted, it has to have some form of machine perfusion, we can change that. There are lots of different types of machine perfusion. And this is where it gets a bit too technical, hopefully not too technical, but I will talk you through each of these different options and when we do them and when different places use them. So on the far left of the screen, SCS stands for static cold storage, and that is a fancy term for a box of ice. And it is literally an ice box, and the liver is sat there and we're not doing anything to it. That's what used to happen. That is still what we do for most DBD livers, is that we don't really do anything to it. It gets retrieved, all the blood gets flushed out of it, it gets cooled down on ice, and then it gets put in an ice box and gets transported that way until it's ready to be put in. NMP stands for normothermic machine perfusion. And that is where we perfuse the liver at a normal, warm, oxygenated environment, trying to replicate the environment that the liver is in when it's inside a body. So we perfuse it with blood at a normal 37 degrees, and we try and give it all the nutrients that it would have if it was inside someone's body, to try and keep the liver alive as if it had never come out. And the names of the devices that can do that are listed below that. The most well-known one is what's called OrganOx, which has had a few papers published and has been in the press a few times, and so you may have heard that. There is an alternative called TransMedics, which is more popular in the United States than in the UK, but it effectively does the same thing. And normothermic machine perfusion can be delivered either in transit, and that means that we take the machine with us to where the donor is, put the liver on the machine, and it gets transported whilst being perfused, or it can be done back at base. And that is, the liver is retrieved as normal, transported on ice, and then once it's arrived at the transplanting center, then it gets perfused with machine perfusion. That's what we call NMP at base. So there, as well as the OrganOx and the TransMedics machines that can do normothermic machine perfusion in transit, there's an added machine called LIVErassist, made by Ex Vivo, that can do normothermic machine perfusion, but not in transit, only once it's arrived back at base. The third option is hypothermic machine perfusion, or HOPE, which stands for hypothermic oxygenated perfusion, which are just different terms to the same thing. And that is where we're not trying to replicate a physiological environment. We're not trying to make the liver think that it's inside a body. All we're trying to do is give enough oxygen into a liver at a cold temperature so that we can restore the energy levels within the liver before we can put it into somebody. That is the majority of what we do in Newcastle, is HOPE, or hypothermic machine perfusion. And again, there are a couple of different devices that can do that. And then the fourth option, or the last option we're going to talk about briefly, is normothermic regional perfusion. And that is where we go to where the donor is. When their heart has stopped, we then put big tubes in their aorta and their vena cava, and we try and restore warm circulation into the donor, into just the abdominal organs, to bring the organs back to life whilst still in the donor, and effectively try and turn a DCD donor into DBD donor. So although their heart's not beating, we're using a machine to give oxygen and blood to the organs in the abdomen as if the heart was still beating. That has been shown to have some advantages, which I'll talk about later, although logistically is quite challenging to deliver, as you can imagine, trying to take all of that kit to where the donor is, as well as the personnel and expertise required to deliver it. The names of the devices, which I don't expect you to remember below there, but the ones that are listed in orange color are all devices that we now have in Newcastle available to us, and the white ones are the ones that we don't have in Newcastle, but which don't offer anything different to the ones that we already do. So in essence, we have the technology available in Newcastle in the Institute of Transplantation to deliver any one of these different perfusion options, depending on the specific scenarios as to which one is better. And that's a timeline of what we have delivered in Newcastle in terms of machine perfusion over the years and how we've delivered it. So it started 10 years ago with my PhD, where LIVErNORTH gave us a generous amount of money to get us started with that research, which we then, in the beginning of 2016, started translating into clinical practice. So 8 years ago was the first time that we transplanted a liver after machine perfusion here in Newcastle. We were the first in the UK to transplant a liver after hypothermic machine perfusion, and we've continued to champion that as the best option for machine perfusion available, with growing evidence to support that, which I'll talk about later. We've changed which device we use to do hypothermic perfusion gradually over the years with some overlap, but now we predominantly use the liver assist device. In parallel to that, we've also had normothermic machine perfusion with the Organox device for the last 4 years or so. And for the last 3 years, we've also been doing normothermic regional perfusion using a different device. There's some pretty pictures of what the devices look like. The ones on the left are the ones that we have here, and the only one of them that we do not have in Newcastle is the Transmedics device, which doesn't do anything different to what Organox does anyway, so there's no reason for us to have it in addition to what we do. This is what a liver looks like whilst being perfused. So this picture was taken fairly recently, within the last few weeks. And this is on the liver assist device, and this is a liver being perfused cold. So it's hypothermic machine perfusion. So there's no blood. This is preservation solution at around 6, 7, 8 degrees, but full of oxygen being pumped into the liver. And the research has shown that whilst the liver is being transported in that ice box, the energy levels within that liver has been dropping gradually over time, so that by the time it arrives here, it is depleted of ATP, or the energy stores within the liver. And by pumping it full of this oxygenated fluid, we can build up that energy level back up so that we can restore the quality of the liver before it gets transplanted. You can see that this perhaps looks like a bit of a messy picture, and that is intentional, because actually we have now started a process where as soon as a liver arrives in Newcastle, we can get it onto perfusion within a few minutes to save time. And then any additional work we need to do on the liver, such as reconstructing any blood vessels, we can do it whilst the perfusion is already running. So we're saving time with that. So all these instruments that are on the table there are because we, on this particular liver, had to reconstruct the artery whilst the perfusion was already running. I'll stop there briefly, just in case there are any questions. Does anybody want to stop to ask me any questions at this stage? Okay.
Hi, Rod. I will,
Yes.
if that's okay.
Yes, please.
We funded some work with Colin Wilson for the Organox machine.
Yes.
It was a while ago, maybe about 5 or 6 years ago. And at the time it was brilliant. It was something that was fantastic, and it was making livers available much more than it had been in the past. And is it still the gold standard, the Organox, or are they all the same?
I will answer that question with my next few slides, if that's all right with you.
That's fine. Yeah.
Karen, you've got your hand up as well.
Yes, thank you. Just a couple of questions. So firstly, how are these machines financed? Have you bought them? Are you renting them? Are they being lent to you because they're new technology? How does all that part work?
That's a very good question and very topical. So I'll talk you through them, each of them. So the Organox machine is on loan to us. It was funded through a research trial which we participated in, and the consumables for it are still subsidized as part of that. So we don't own it; it is simply on loan to us. Similarly, the VitaSmart at the bottom there is also on loan to us. We also do not own it. However, the company who manufactures it do profit from the consumables that we purchase for it. However, it is technically on a trial basis for us to try out the machine. We'll see whether we like it or not. The liver assist device, which is the one with the 3 orange vertical devices underneath the liver, that has been funded for purchase by the Newcastle Hospitals charity. So they have awarded us £100,000 for the outright purchase of that machine. And then similarly, the Mackay Getinge machine in the bottom left-hand corner has also been purchased outright using charitable funds as well, which I'm pretty sure that's also from Newcastle Hospitals charity. Does that make sense? The consumables for them, which is also a significant expenditure, it's for most of these devices, it's somewhere between £4,000 and £6,000 per liver when we want to perfuse them. That is now paid for by the trust itself. But it's been a very long, drawn-out fight with the trust to get them to be convinced that this was money worthwhile spending. But they have now agreed to that.
Thank you. The second part of my question was about health economics, and how have you been able to build a case that says that this is an investment worth spending because people stay in hospital less, or they don't have so many complications post-transplant or anything like that?
So there is good evidence, particularly for hypothermic perfusion, that the health economics do support it, both in terms, there are multiple factors that contribute to that. And so in theatre, the reperfusion dynamics, and that is what I mean by that is once we let the blood flow into the new liver, the recipient is often very unstable at that stage because it's a new liver that's washing out lots of toxins into the body. By doing machine perfusion of any description, but particularly hypothermic, that reduces that hit to the donor, and therefore there is a reduction in the number of blood products that are needed at that stage. So that's the first cost saving. Secondly, there is good evidence to suggest that the length of intensive care stay is shorter with a perfused liver. Total hospital stay is shorter, and so therefore there is a substantial cost saving in that. But the third biggest cost saving is repeated procedures, and that is what I mentioned before about ischemic cholangiopathy. Ischemic cholangiopathy almost always results in repeated endoscopic procedures to try and put stents in, to try and unblock the liver, to try and improve the bile drainage. Each of those are repeated admissions, requiring sometimes intensive care stay, requiring multiple endoscopic procedures, and the cost savings are unquestionable. So there is no doubt that this is good use of money, and the evidence supports that very easily. But as I'm sure you understand, that no matter how good the evidence is, it's not always that easy to convince NHS people who hold the purse strings that spend £100,000 and you'll easily get that money back, because it's not always that simple. But the evidence does support that.
Thank you.
So I am going to talk a little bit about the evidence comparing the different types of perfusion, and the reasons why we have moved towards hypothermic, that's cold perfusion, being our first choice for perfusion, although not exclusively, and there are specific circumstances where it's not necessarily the best option. So we recently published a Cochrane review, which is a highest level of evidence comparing all the different randomized control trials done throughout the world, comparing machine perfusion to static cold storage. And we combined all the data from all of those studies to add power to the data and also allow us to compare them together. So there are there are a few studies comparing cold perfusion with nothing, and there are a few studies comparing warm perfusion with nothing. There has never been any randomized trial comparing warm perfusion versus cold perfusion. There are lots of reasons for that, and finance, and also the logistics of it, and also the availability of having multiple perfusion technologies within individual centers has meant that has never been able to be reproduced. But if we have cold perfusion versus nothing and warm perfusion versus nothing, and we can combine that data, we can also compare warm versus cold indirectly. For clarity, for normothermic regional perfusion, which I've mentioned before, there is case data from the UK, which is very supportive of it, but there have never been any randomized controlled trials, which is our highest grade of evidence. There have been none comparing supporting normothermic regional perfusion. So this is HOPE versus static cold storage, and that is hypothermic perfusion versus doing just an icebox. And when you combine all of the data, looking at graft survival, you can see that diamond-shaped box being to the left of the midline means that there is evidence to support its use. And the fact that that box does not cross the midline at all means that that is statistically significant. So there are 4 randomized controlled trials comparing HOPE versus static cold storage, and there's high certainty in the evidence that it improves graft survival. And similarly, when you look at the incidence of serious adverse events, which is where the health economics becomes important as well, there is also a statistically significant improvement in the incidence of serious adverse events within 3 months of a liver transplant if we do hypothermic perfusion first. And lastly, there are additional benefits with a high certainty that it improves clinically significant ischemic cholangiopathy, which is the last thing at the bottom there. Whereas when we compare similarly normothermic machine perfusion, which is what OrganOx does, versus static cold storage or an icebox, there is not that evidence to support it in terms of improving graft survival or reducing serious adverse events or reducing clinically significant ischemic cholangiopathy. Now that might sound fairly disappointing, in that normothermic machine perfusion, according to the evidence that is presented, does not make a liver better, basically. However, what it does do is it buys us more time. It does 2 things. It buys us more time in that if we need to preserve a liver for longer than we would normally do, normothermic machine perfusion can do that safely. And there are lots of reasons why we might need to preserve a liver for longer than expected. But perhaps more importantly is that OrganOx, even if it doesn't make a liver better, it does give us more information about a liver. And so if there is a liver where we would ordinarily decline that liver because we consider it, too high risk, or we need more information about it, if we can put it on normothermic machine perfusion, because that liver is effectively alive as it would be in a human body, we can test its function and we can gather more information about its viability and make a more informed decision about how safe it would be to transplant this liver into a recipient. And that leads to improved utilization. Across the world, the data shows that if you have normothermic machine perfusion available, you are more likely to transplant marginal livers than if you did not. What I'm trying to say is that HOPE, or cold perfusion, if you have a marginal liver, HOPE will make it better and will reduce the risk of complications. Normothermic machine perfusion probably does not make that liver any better, but it will give us more information about the liver so that we can make a more informed decision as to whether or not it's safe enough to proceed with the transplant. Does that make sense? Okay, I see some nodding heads, so I'll move on. So the Newcastle experience of what we have done so far, this slide is one case out of date because I did it last week. So we have one more HOPE since then. So we've now transplanted 50 livers in Newcastle after HOPE perfusion. We've done more than that because there are a few that we did HOPE and we did not transplant, but we have now transplanted 50 livers over the last 8 years or so. There's been an exponential rise in its use in Newcastle. So a significant portion of them are within the last 2 or 3 years, but effectively we've been doing it for 8 years. Of those 50 livers, not a single one has developed ischemic cholangiopathy. One patient has not had it confirmed, but some blood tests do suggest that he or she may be developing some cholangiopathy. So it's possible that it might be 1 out of 50. But still, if you compare that to the figure I quoted you at the beginning, which is that without machine perfusion, about 1/4 to 1/3 of these livers should have developed cholangiopathy. We are either nothing or at worst at 2% rate, which is actually better than the DBD rate of ischemic cholangiopathy. Of those 50, 2 have had retransplants. One of them was because of rejection, and so therefore that is not related to perfusion, and perfusion had never had any hope of trying to make that better. That is unfortunate circumstances. And the second was due to hepatic artery thrombosis, and that's where there was a blood clot within the artery and it needed to be retransplanted. That was during a period where, I'm going to go back a few slides to the timeline. So if you look at the third line there of VitaSmart, that is one of the devices for hypothermic machine perfusion where we perfuse only the portal vein and not the artery, which is fairly commonplace in lots of places around the world. But it was during that period where we were doing just portal vein perfusion where that one patient had developed hepatic artery thrombosis. So we have moved away from that and now gone back to what we used to do before of perfusing both the artery and the vein. I'm not saying necessarily that was the reason why that happened, but we feel a bit more comfortable knowing that we have perfused both the blood vessels. 3 patients have died after receiving a liver transplant that had undergone HOPE perfusion. All 3 of those deaths were not related to the perfusion directly. 2 of them happened years down the line of completely unrelated cause. One of them unfortunately did die within a month of transplant, having had a stroke at home. Again, very unfortunate, but I don't think that perfusion had any way of trying to prevent that from happening. Our experience with normothermic machine perfusion, we have transplanted 7 livers after normothermic machine perfusion, a much lower rate. We've done it far less than we've done HOPE, although we have perfused significantly more numbers than that we have then not transplanted. And as I take you back to what I said before, that the main reason for doing normothermic machine perfusion is to gather more information about the liver to decide whether or not to transplant it. So by definition, a lot of these livers, we will not like the information that we've received and therefore will not choose to proceed with the transplant itself. But of those 7, 1 has developed ischemic cholangiopathy and 2 have been retransplanted, again for different complications, but all 7 are still alive. And then lastly, normothermic regional perfusion, which is where we go out to the donor and reperfuse the organs whilst they're still inside the donor. I believe we've done 11 of those. That might be 12. I need to double check that actually. We might have done one last week that I've not updated on here, but we transplanted 11 livers after normothermic regional perfusion and have had no complications from any of them. So when do we decide what perfusion technology to use? And forgive my car analogy, but I'm a bit of a petrol head, so I had to include this. So if we have a good quality donor, DBD, young donor that we have no concerns about the liver, we do not do any perfusion technology at all. Those livers go from static cold storage, transplanted straight away. There is no justification for the added time or cost of doing machine perfusion to those livers because the evidence does not support that we will make those livers any better by doing machine perfusion. So we don't do it routinely unless there are any particular concerns. And then the middle road. So these are actually if you remember from that slide at the beginning, that over half of the livers that we transplant in Newcastle now are DCD livers. So these are livers that we consider to be transplantable, but are higher risk. If we do nothing to these livers, the risk of them developing complications are higher than if we used the first slide, the Ferrari. And so for these patients, we use what we call end ischemic hope. And that is when the liver arrives here, we put it on hypothermic perfusion, and we have demonstrated that it delivers better graft survival with a lower risk of serious adverse events and next to no risk of ischemic cholangiopathy. And then the third option is where we have this old banger. We have a liver that we ordinarily would consider untransplantable. We think the liver is not good enough to put in, but rather than say no, if there's something that we think is potentially rescuable, those are the livers we then put on normothermic machine perfusion to gather more information about it. And in most cases, based on the information we gather, we still do not transplant them. But in a significant number, we are reassured enough by the numbers that we can gather from the viability testing to show that actually the liver is safe enough to proceed with the transplant. And by doing that, we can improve utilization, i.e. we can use more of the livers that are available to us and better serve our population. And lastly, if there are logistical or recipient factors that mean that we need to delay the transplant. And the only examples of that really are if we are already in the middle of a transplant and we physically cannot do another one side by side, and therefore we have two options. Then we either turn down the second liver or we accept it and use perfusion technology to try and prolong the time that we can keep that liver alive for before doing the second transplant. We can do that with hope to some extent for several hours, but there is good evidence that normothermic machine perfusion can safely do that for up to 24 hours and perhaps even beyond. That is a pretty rare occasion in Newcastle, almost unheard of, because our volume of transplantation does not very often lead us into that situation where we have two transplants to do simultaneously. Extremely rare. The second factor is if there are recipient issues. For example, if it's a redo liver transplant, it's going to take us a while to get the liver out and get it ready for the new liver to go in. And we may choose to do normothermic machine perfusion in order to buy us more time so that there's less pressure to get the liver out, do the hepatectomy in the recipient. And this is the algorithm that we use in Newcastle for when we use each different type of perfusion technology. So if it's a DBD, it all usually goes straight to transplant unless there are viability concerns or we need to extend the preservation time to a significant amount. And then we would use normothermic perfusion. If it's a DCD liver, I put the first thing there is whether NRP is available. And so NRP is, although there is not good randomized controlled trial data to support it, there is good growing evidence that it is good and that it gives us best of both worlds in that it makes the livers better, plus it gives us viability information at the donor site as to whether or not the liver is working well. The problem with it is that it is logistically very challenging to deliver because one of 3 surgeons in Newcastle who are experienced in doing NRP would need to go out to where the donor is, plus perfusion staff who are familiar with running the machines simultaneously would need to go out to where the donor is. We at present do not have 24/7 availability to be able to deliver that. And I'm not sure that we ever will, to be honest with you, because I think the staffing requirements to deliver that are substantial. But we do try. And so if we have the personnel available to do NRP, then we will do. If not, then we accept the liver and we bring it to Newcastle. Once it arrives, we do hope perfusion. And occasionally, although very rarely, if after that we still have any concerns about the viability, we may still choose to do normothermic machine perfusion as well as that. Although I could count on one hand the times where that has happened. And that is the end of my presentation, but I'm happy to take any questions or help to clarify anything that has not been clear.
That's excellent, Rod. Thank you very much. Any questions? Put hand up if anyone has anything to ask. Karen, you had a good question last time. Let's have yours.
Oh, me again. So, my interest is from a donor family point of view, and how has this intervention where you're actually using the perfusion machine while the organ is still with the donor, how has that been received with the donor families?
Generally very well. It is a sensitive topic that needs to be handled very carefully, and there are lots of regulatory requirements in order for us to do this. And the important thing that we have to make it extremely clear to donor families is that we are not bringing the donor back to life again. Mm-hmm. This is purely about the organs in the abdomen. Mm-hmm. And that needs careful explanation. And there are lots of things that we have to do to make sure that we are not perfusing anything above the diaphragm with the warm oxygenated blood, because we are not trying to bring the donor back to life again. So we have to open the blood vessels that supply the head. So effectively we put a cannula into the aorta, forgive me if I'm being too graphic, a cannula into the aorta up in the chest, which we open to room air to make sure that no blood is getting up there, to make sure, be certain that we are not perfusing anything above the diaphragm. But effectively, we explain to the donor families that we are trying to revitalize the organs below the diaphragm by giving them warm oxygenated blood so that we can test how well those organs are working, and also make sure that when we take them out, they are in the best quality they can be, which can improve the utilization of those organs. And ultimately that when donor families are invested into this and have bought into the process of organ donation, my feeling is what they want to see is that something's going to come out of it. And if we can demonstrate that by doing this, that we can improve the utilizations, i.e. there's a greater chance that the organs from their family member are actually going to come to good use, then our experience is that the families are on board with that. I must admit that is not my personal job to have that discussion, and we don't get involved in the individual family discussions. Ultimately, we potentially could have a conflict of interest in there, so we deliberately have no direct relation with the families. But our conversation with the SNODs, the specialists for organ donation, is that it has been positively received, so long as there is a sensitive and careful explanation as to how it works and why.
Mm-hmm. Thank you.
Very good. You said in the talk about one of the things you talk about is the future of liver perfusion.
Yeah.
And I just wondered where it's going.
So I believe that the future, I don't know how soon into the future, is that we will have organ reconditioning centers where we can centralize this expertise and the technology so that the organs that are currently turned down would all be taken to a centralized location. I don't know where that would be, where these organs would then be perfused to then make them better. And this is where normothermic machine perfusion has not yet come into its own yet, I don't think. I've shown to you that I don't think normothermic machine perfusion on its own makes the liver any better. But that's because we're only talking about just perfusion. What isn't as yet untapped potential resource is to use normothermic machine perfusion as a platform to modify organs. Now, I use that word slightly cautiously. By modify, I mean treat a liver. So if you have a fatty liver, I believe that we will at some point be in a position where we do not turn down a fatty liver, we accept it, we put it on machine perfusion, and we use different drugs to make those organs better. I've used fatty liver as an example, but there are other potential reasons why livers might be declined that we can treat whilst it's outside of a body before it being transplanted. And I think that's where the next 10 years is going to take us in terms of machine perfusion technology.
That's great. Ray got his hand raised.
Actually, I think you've just answered the question I was going to say. I am not involved in liver transplants. My wife has a kidney transplant, and I belong to the BTRU in Newcastle, the Patients Forum. We were talking about perfusion years ago, and one of the main things that they did say was if you've got that organ out of the body, you can then give it some drugs which will clean it up, which you can't do when it's in the body. Is that
absolutely so?
With livers as well?
Yes, exactly. So as well as treating livers with drugs that we could potentially give to you and I, there's the unique benefit that there are potential treatments that could be toxic to give to a human being as a whole, but you could potentially, or different doses of drugs that you could potentially deliver to a liver in isolation that the liver will tolerate whilst it's outside of a body. So particularly from a defatting point of view, so there are potentially drugs at doses that you could not give to a human being, but that you could give to a liver that would be effective in the liver, and then would be safe to then transplant that liver later on because those drugs could be washed out. Does that make sense? So there is a unique potential to treat organs outside of the body with potential treatments that you could not deliver whilst they are still in.
Yes, thank you.
That's really interesting. I mean, one of the things that's happened in the lifetime of LIVErNORTH and in the recent history is the cure for hepatitis C. Absolutely. And I just wonder if you could find, how long can you perfuse a liver that can, give it, infuse these drugs that work overnight, or is it?
So hepatitis C, we probably wouldn't be able to clear from a liver, I don't think. No. Unless the technology that continues to progress over the next 10 years and it becomes even more advanced. However, as you rightly say, the hepatitis C treatment has changed so much in the last 10 years that actually, if we have a good donor who has hepatitis C, we would have a discussion with the recipient. And so long as they consent to it, we would still transplant that liver and treat the recipient.
Yeah, of course.
So that's not necessarily a barrier so long as the recipient consents to it, which most do actually, because the treatment is so effective nowadays.
Well, it's a life-saving operation, isn't it? You haven't got much of a choice.
As with all these things with livers, it's there's never individual specific risks. It's all about cumulative risk. Yes. And so if you have a very healthy liver from an 18-year-old DBD, for example, with no other past medical history, but they have hepatitis C, I think that's a no-brainer. That is a small risk in the grand scheme of things. That might be different if you have a 70-year-old fatty DCD liver from someone who used to drink excessively and they have hepatitis C. The cumulative, it is one added factor to take into consideration, which might occasionally tip you over the edge to something becoming untransplantable. But in most cases, hepatitis C is not a reason not to transplant nowadays.
Excellent. Have we got any more questions for Rod? No. Well, that's brilliant, Rod. I wonder if there's a question in the chat. Does the current consent form patients sign when they are listed for, let's have a look, when they're listed for an organ transplant include these perfusion options?
Yes.
The consent form, yeah.
So any patients who are currently being consented to be added to the waiting list, we will, or at least we should, mention to them. So we, as part of the consent process, we would explain to them the differences between DBD and DCD donors. And as part of that, we explain to them that if we accept a DCD donor as part of that, the liver will have some form of machine perfusion. It has been over 2 years now since the last time we transplanted a DCD liver without machine perfusion, and even that 2 years ago was a rarity. We have no intention of ever transplanting a DCD liver in Newcastle without machine perfusion ever again, and the data does not justify it anymore.
Excellent. Now we've got 2 questions. I think I've got Nigel first, then Gavin. Is that right, Gavin? Yeah, Nigel first then.
Just picking up on John's point about the future, is there anything happening these days in regard to the live donor program nationally? Is there improvement coming along, or is it still as risky as it's always been?
No, so live donor liver transplants are very safe. As you probably know, lots of parts of the world do it very routinely. In the UK, we had been a bit behind in terms of doing live donor livers. But as one of the strategies that NHSBT nationally want to use to address the mismatch of the number of people on the waiting list versus the number of donors is to develop the live donor liver program further. And so there is a national program that is being set up and due to start imminently to encourage individual centers to start doing more live donor liver transplants with the support predominantly of the Leeds team, who are the centre in the UK with the most experience of live donor liver transplants. And so we do intend in Newcastle to be part of that. And although it's maybe early days to talk about it too publicly, but I do expect that within the next year or two, we are likely to be starting live donor livers in Newcastle.
Excellent. That all right, Nigel?
Yeah, thank you. I do have an interest in that. I'm one of the Human Tissue Authority independent assessors, so it's just
right.
A background on that. I do it for the kidney program for Newcastle. So yeah.
Obviously, that it's not right for everybody,
yes,
as it isn't with kidneys. But
yeah.
More specifically, the risks to the donor for a live donor liver are higher than they are for live donor kidney, and so that needs to be weighed up very carefully. But there are recipients for whom live donor livers are probably the best option. And I won't go into the nitty-gritty of the allocation process for livers in the UK, but there are definitely groups of patients who are disadvantaged, who are not likely to receive a good quality liver offer anytime soon. And some of these are particularly young patients with PSC or some other variant conditions, where the score that is used to judge how likely they are to get a liver offer for those patients is very low, which means that they will never or not anytime soon get a good quality DBD liver. And so for those patients, the options are DCD or a live donor liver. And particularly in young patients, because our donor pool is also not particularly young, so if there are young patients who are needing a liver transplant, I do believe that those are specific circumstances where actually they will do better with a live donor liver, so long as it's considered carefully.
Good. Thanks, Rod. It's good to know it's moving on. Thank you.
Excellent. Galvin, you had a question?
Yeah, as a recipient 8-month post-op, I was just wondering, am I allowed access to find out about my liver journey, about sort of what type of perfusion it had, or
yes,
absolutely, it's a question I've never asked, or
yes, definitely. You there are specific details regarding that could identify the donor, which we would not share with you, but absolutely the type of donor, the type of liver that you had, and whether it was machine perfused or not, and what type of machine perfusion it had. If it did, absolutely, you're entitled to that information. So the easiest way to do that is if you speak to Peter Robinson-Smith or Helen Dobson, the coordinators. They will be able to share that with you.
Thank you.
And if you want to have a discussion about specifics of that and an explanation as to why we did what we did, then I'm happy to meet with you one-to-one and have that discussion with you as well.
Thank you very much.
Well, that's excellent. We've got Paul now on the. He's one of our helpline people. He's got a question for you.
Pardon me. The machinery you've shown us a clip of before, a slide of. Am I to assume, due to the value of them, you only have one of each piece of equipment?
Correct.
So what's the contingency for any malfunctions or even the people who've donated and requesting them back?
Very good questions. So through that. So as I mentioned to you before, the only two that are in clinical use that we actually physically own outright are the liver assist device and the Getingi NRP device. There is a possibility that the that OrganOx gets taken away from us, particularly as we don't use it that often. The contingency for that is that the liver assist device can do the same thing that OrganOx can, and we own that outright. So that was one of the selling points to make sure that we got the funding for that, is that that's one device that can do warm and cold perfusion, and therefore if we have that in-house, bought outright, fully paid for, then that takes away some of that risk. The VitaSmart device, which is also on loan, I think there's a very real risk that that will be taken back. But again, to be honest with you, that doesn't do anything that the liver assist doesn't. And so I'm not particularly concerned if that does happen. With regards to malfunction, so there's two ways to look at that. One is a malfunction whilst a liver is being perfused. And one of the advantages of doing hypothermic, cold perfusion, versus warm perfusion is that if it malfunctions, worst case scenario is you're back to static cold storage. So if you have a liver on cold perfusion and the machine has a complete meltdown and it stops, it's still on ice, so it's safe. Whereas with OrganOx or any other warm perfusion technology, if you have a complete disaster, then you potentially lose that liver. Because you would have a warm liver full of warm oxygenated blood that then stops. That liver would be damaged unless we can rescue the situation very quickly. So that is one of the added risks of doing normothermic machine perfusion, although that has never actually happened to us, but it has happened elsewhere. The second thing to look at is whether you have not an immediate malfunction whilst the liver is on it, but rather a problem with the device, which means that we can't use it. And for example, I don't know, fails its servicing or something. That also, we've never been in that situation either. At the moment, we have enough redundancy in the number of devices that we have here, so that if one became unavailable for whatever reason, I'd be comfortable that we could continue to deliver as good a quality of a service with no interruption. But worst case scenario, if we were to lose our OrganOx machine and our VitaSmart machine, and then our liver assist machine then failed for whatever reason, then we would then be in a position where we would not be able to transplant DCD livers unless we could resolve the problem quickly. We have a very good relationship with the company. We're based in Holland. I am pretty confident we would never be in a situation for more than a day or two. Worst case scenario, if all of these Swiss cheese holes aligned and we ended up in a disastrous situation where all of them were out of action, I'm pretty confident that would not be the case for more than a day or two. So I think we have a fairly robust contingency plans, although not completely fail-safe.
Excellent. You okay with that, Paul? Good lad. Yeah, where's the next nearest one, Rod, if we have a complete breakdown?
So Leeds and Edinburgh both have a liver cyst.
Yeah, right.
And
Yeah.
so that is, I didn't want to say that too publicly because we don't have that official agreement with them, although both Leeds and Edinburgh have helped us out in terms of consumable circuits. So we've had situations where we never keep loads of them on the shelf, partly because they take up space and partly because they have a finite expiry date. So we never choose to have dozens on the shelf. But then if we end up with a particularly busy week or two and run short on circuits, we have borrowed some from both Leeds and Edinburgh in the past, just whilst we get our own stock back up again. And that's a reciprocal arrangement that we have with both of them. When they need us, we're happy to help them as well.
Excellent, excellent. Well, that's great. A really interesting talk. I'm grateful to you for giving up your time. Would you come back and give us another update next year?
Yes, sure.
Yeah.
Very happy to.
So thank you for that. Anyone who works for the NHS can have 2 hours CPD, claim 2 hours CPD for watching this. So that's good.
Yes.
And you're in the middle of now at the Freeman going through your IQUILS registration and assessment. So if you tell your colleague Aaron Wetton that you've given us this talk, that may well help. And the proof is the video, which will be on our YouTube channel.
Fantastic.
Okay, so thank you so much. And we're all extremely, I bet you didn't think there was going to be so many expert patients.
Well, it's great to hear that, actually, and I would always promote education in our patients, and this is a complex journey for all of us, and having patients on board the journey, understanding the complexities of what we're trying to explain to them, it makes our lives much easier. And if anybody who's on the call doesn't want to have a public conversation about any questions but want to speak to me privately, I'm more than happy to. Probably you can get my email address from John, or you can contact Peter or Helen at the Freeman, and they can help to put you in contact with me. Very happy to take any private questions or individual discussions if that's helpful to you.
No, that's absolutely fabulous. Well, thank you so much, and we'll stop the recording